Good morning, esteemed members of press and media. With the permission of Dean Sir, I would like to start the press conference.
Yes.
Today we have gathered here for a press conference on a project entitled Mission, a multi-centric capacity building initiative to strengthen the clinical and laboratory detection of melioidosis in India with special focus on the north states. I would like to introduce the esteemed members of the team from SMIMS and the team from KMC Manipal to the members of press and media. Dean Sir, Dr. Muralidhar V. Pai, Dr. Chiranjeev Mukhopadhyay, Professor, Department of Microbiology, KMC, and Chief Principal Investigator of the project. Dr. Tejaswi S.C., Professor and Head, Department of Orthopedics and Clinical Co-PI of the project from SMIMS. Dr. Varun Singh, Professor, Department of Surgery and Clinical Co-PI from SMIMS of the project. Dr. Deepan Gautam, Department of Microbiology Co-PI of the project from SMIMS. Dr. Mohammad Ashik, member from KMC. Dr. Ms. Pranomita Chakrabarti, SRF of the project from SMIMS. I am Dr. Luna Adhikari, Professor, Head, Department of Microbiology, SMIMS, and the Principal Investigator of the project. Now, I would like to request Dean Sir to address the press conference.
Thank you, Dr. Luna. And thank you all of you for attending this press conference. I would like to take this opportunity to express my sincere appreciation to Dr. Harpreet Kaur, Scientist G, ICMR New Delhi, and Dr. Chiranjeev Mukhopadhyay, Professor and former HOD of Department of Microbiology, Kasturba Medical College, Manipal. He has also been the Associate Dean of Research for 6 years in Kasturba Medical College, Manipal, and the Chief Principal Investigator of the project, Dr. Chiranjeev, and PI, that is the investigator in Sikkim, Dr. Luna Adhikari, and also the other co-PI, Dr. Varun Singh, Professor of Surgery, and Dr. Tejaswi, Professor and HOD of Orthopedics, and Professor Mona, she's a professor in medicine, and also Dr. Deepan Gautam, co-PI. The project is recognized to be done in SMIMS, Sikkim, as one of the centers. We are also grateful that SMIMS has been chosen as one of the key centers for this project, which has been just informed by Dr. Luna, that is Mission, a multi-centric capacity building initiative to strengthen the clinical and laboratory detection of melioidosis with special focus on northeastern states. Through this initiative, our faculty members have been equipped with the necessary knowledge and skills to enhance the diagnosis of melioidosis, both clinically and in the laboratory, and to ensure timely and effective treatment for affected patients. This project has strengthened our institutional capacity, enabling us to contribute meaningfully to public health and infectious diseases management. I would like to briefly inform you about melioidosis. It's a potentially fatal infectious disease caused by the bacterium Burkholderia pseudomeli. This disease is commonly found in tropical and subtropical regions, particularly in Southeast Asia and Northern Australia. It spreads through contaminated soil and water, mainly affecting humans and animals through inhalation, ingestion, or direct contact with the broken skin. Melioidosis presents a wide range of symptoms from mild fever to severe pneumonia and septicemia, making it difficult to diagnose because it camouflages itself and very difficult to diagnose. It is especially dangerous for individuals with underlying conditions like diabetes, or kidney disease. Without proper treatment, it can lead to life-threatening complications. Given its high mortality rate and potential for antibiotic resistance, early detection and appropriate antibiotic theory are crucial. Raising awareness about this disease, especially in endemic regions, can help improve diagnosis, treatment, and prevention strategies. So, we are happy that SMIMS has been chosen as one of the centers for this particular research project. So, I would request now the chief of this project, Dr. Chiranjoy, to tell us more about this.
Thank you, sir. Very good morning to all of you. Very good morning to my esteemed faculty here. And I'm thankful that you are all attending this one. We want to convey a very important message to all of you about an emerging tropical disease. The disease, as mentioned, it is called melioidosis. Sometimes it is called soil fever because the bacteria Bacteria pseudomyeli is in the soil and water. And any person who gets exposed to soil and water, especially if they are diabetic, if they are having kidney disease, they are chronic alcoholic, they may get the disease, and many times it is fatal, it is life-threatening. Maybe sometimes out of 5 patients, 1 may die. Especially if they come in the heavy rains, they come with pneumonia, they come with bloodstream infection, or they come with bone and joint infections. If they are not treated immediately and not diagnosed, the outcome may be very fatal. We are very fortunate to have a very good laboratory setup in SMIMS. And SMIMS is the nodal center for this particular disease in Sikkim because of their excellent laboratory capacity and the expertise that they have developed. So any such disease, if can be suspected by any clinician, our main message is for the clinicians. 2 clinicians are there with us and they are trying their best that we can save human life. If clinicians suspect the disease and they refer to the microbiology laboratory is able to diagnose the disease at the earliest opportunity. And if they diagnose, the treatment is available. And the antibiotics are available. If the antibiotic is given at the right dose for a right duration, human life can be saved. So you understand the most important message about this, that one diagnosed means one human life is saved. So we are here all together to convey this message through you to all the clinicians across the state and all the microbiologists across the state and the public health officials and the government authority that this is a disease which is very much prevalent but underdiagnosed, misdiagnosed. If it is not diagnosed and if it is misdiagnosed as other diseases like tuberculosis, leptospirosis, scrub typhus, the treatment will be wrongly given and the patient will never be cured and they will have a very fatal outcome. So diagnosis is important. In many states of Northeast now, once they were not diagnosing this disease at all, so patients were going down to south and getting them diagnosed. So when we look at the data from south hospitals, the reputed hospitals from the southern part of India, many of the patients who have traveled from northeast and they have gone to the south and they got diagnosed. So we can understand that how many patients who got misdiagnosed or underdiagnosed here. Now once we started the project in northeast like Mizoram, Assam, Tripura, Manipur, Meghalaya, all have started diagnosing melioidosis. And many human lives are being saved. One center is in SMIMS, Sikkim, and they are having the exact capacity, appropriate capacity, and the awareness. So please take the help. Through you, I want to convey the message to everyone. Please take help of them. Any patient who is suspected to have pneumonia, bloodstream infection, bone and joint infection, deep abscess in the body, liver abscess, spleen abscess, prostatic abscess, parotid abscess, cervical lymphadenitis, subcutaneous abscesses, or the patients having meningitis sometimes. If you suspect, please refer to the laboratory here, consult the clinicians here who will help you diagnose melioidosis. If not melioidosis, you can get another diagnosis, but it will never be misdiagnosed or underdiagnosed. This is the message from our side. So, keeping this center as the nodal center, we are now, as a hub and spoke model, we are following and we are connecting the peripheries. So there are 4 PHCs. One is Temi, Nangthan, Meli, Rangpo. These are the 4 PHCs we have already connected, and we have visited them, and we are asking them if they suspect any patient. We are having 2 district hospitals. One is Namchi and Singtam. They are a part of this project, and we have one CHC is Renok. They are a part of this project. So we are now expanding it more. More the awareness will be done, more number of patients will be diagnosed. So in this way, this is a project taken which has been conceptualized by KMC Manipal with the help of ICMR, and we are very grateful to ICMR for funding us to explore the opportunity to diagnose this emerging tropical disease, and we are now trying our best so that we can diagnose more number of cases and save human life.
So thank you, Chiranjay sir. And most of the things regarding melioidosis has been shared by Dean sir and Dr. Chiranjay sir. And in addition to some of the additional information that I would like to give, so it's a multicentric study, 17 centers are involved. So one is the regional center, that is KMC Manipal, and one is the nodal center, that is RMRC Dibrugarh, and 15 are the participating centers. Among the 15 participating centers, one center has been chosen from each of the northeast, and from Sikkim, SMIMS has been chosen as the participating center. And this is the whole project has been conceived by Dr. Chiranjay Mukhopadhyay from KMC Manipal, and it is funded by ICMR. And we started the project since December 2022, and till now we have recruited 145 cases as per the inclusion criteria. And till now we have not detected a single case of melioidosis from Sikkim, from our center. And not only from Sikkim, we have not detected a case of melioidosis from Nagaland and from the Arunachal Pradesh. And this could be due to 2 reasons. One reason is that there may not be any case of melioidosis in Sikkim, in Nagaland, and Arunachal Pradesh, or we may be missing the cases from these 3 states. So because of that reason, more awareness is required so that we should not miss any case of melioidosis. Right? And under this project, we have conducted awareness programs. We have conducted continued CME at district hospitals and PSCs as directed by the government of Sikkim. We conducted awareness program at Namche District Hospital. We conducted awareness program at Singtam District Hospital, and then we conducted awareness program at Rangpo PHC, Namthang PHC, Malli PHC, Temi PHC, and during the awareness program, the healthcare workers of different levels were targeted. Doctors, nurses, lab technicians, and then the ASHA workers were also targeted, and they were sensitized regarding the various aspects of melioidosis. What is the bacteria causing this infection? Where this bacteria is present? How this bacteria can enter the body of the human being? What are the risk factors present in the individuals? What are the risk factors present in the environment? So how the clinical manifestation can be there, and then how to diagnose the case in the clinically, and how to diagnose the case in the lab, and how to treat the patient. What are the antibiotics to be given? Which antibiotics should be given by the oral route? Which antibiotics should be given by the intravenous route? What should be the dose of the antibiotic? And how long the antibiotic should be given? In that detail, it has been trained to all the healthcare workers. And how can we prevent melioidosis also has been shared with all the healthcare workers in the PHCs and in the district hospital. So now regarding melioidosis, Chirandev sir and Dean sir, they have already briefed. And हामीले किन चाहिँ यो केस डायग्नोज गर्नु जरुरी छ, टाइमली यो केस डायग्नोज गर्नु जरुरी छ भने चाहिँ दुईटा कारणले गर्दा। एउटा चाहिँ मेलाइडोसिसको चाहिँ साइन एन्ड सिम्पटम चाहिँ एकदमै वेग छ। सो पेसेन्टले चाहिँ स्किन अल्सर भएर पनि आउन सक्छ, न्युमोनिया भएर पनि पेसेन्ट आउन सक्नुहुन्छ, सेप्टिसेमिया भएर पनि पेसेन्ट आउन सक्नुहुन्छ, और एब्सेस इन द इन्टर्नल अर्गानमा भएर पनि पेसेन्ट डक्टरकोमा आउन सक्नुहुन्छ। एउटा त्यो कारण। अर्को कारण चाहिँ माइक्रोबायोलोजिस्टहरू चाहिँ ट्रेन हुनु भएको छैन भने उहाँलाई चाहिँ ल्याबमा डिटेक्ट गर्नु पुरा गाह्रो छ। बिकज मेथड्स मेलाइडोसिस बर्कोलेरा सुडोमाले डिटेक्ट गर्ने मेथड चाहिँ टोटल्ली डिफ्रेन्ट छ अरू ब्याक्टेरिया भन्दा। अनि अर्को कारण चाहिँ हामीले किन पनि टाइमली डायग्नोज गर्नु जरुरी छ भने चाहिँ यो बर्कोलेरिया सुडोमाली जसले चाहिँ मेलाइडोसिस गर्छ, यसको लागि चाहिँ एन्टिबायोटिक, स्पेसिफिक एन्टिबायोटिक छ, सेट अफ एन्टिबायोटिक छ। त्यो एन्टिबायोटिक चाहिँ तपाईलाई स्पेसिफिक ड्युरेसनमा दिनुपर्छ, लामो ड्युरेसनमा दिनुपर्छ। लाइक अरू ब्याक्टेरियल इन्फेक्सन जस्तो होइन, यसलाई चाहिँ लामो ड्युरेसनमा स्पेसिफिक एन्टिबायोटिक दिनुपर्छ। सो त्यसले गर्दाखेरि टाइमली डायग्नोसिस गर्नु पुरा जरुरी छ। नभए चाहिँ मोर्टालिटी हामीले चाहिँ पेसेन्ट लुज गर्न सक्छौँ। अनि पेसेन्टलाई आधा कल्चो ट्रिटमेन्ट भयो भने फेरि 1 महिनापछि नभए 6 महिनापछि फेरि रिल्याप्स भएर आउन सक्नुहुन्छ। सो रिल्याप्स रेट पनि फेरि पुरा धेरै हाई छ, अराउन्ड 20% रिल्याप्स केस हुन सक्छ। सो त्यो हो। अनि अर्को कुरा चाहिँ हामी चाहिँ यो मेलाइडोसिस प्रोजेक्टबाट चाहिँ द भेरियस क्लिनिकल डिपार्टमेन्ट अफ SMIMS and then the microbiology department of SMIMS, we have been empowered to diagnose the case of melioidosis. मेलाइडोसिस पेसेन्ट आउनुभयो भने CRSमा SMIMSमा हामीले कसरी डायग्नोज गर्ने र त्यसको कुन कुन स्याम्पल पेसेन्टबाट लिने, त्यो स्याम्पल कसरी प्रोसेस गर्ने ल्याबमा सबै हामीलाई ट्रेनिङ भएको छ। सो एनी सस्पेक्टेड केस सिक्किममा हुनुहुन्छ भने उहाँलाई चाहिँ सेन्ट्रल रेफरल हस्पिटलमा रेफर गरे हुन्छ। हाम्रो मेडिसिन डिपार्टमेन्ट, हाम्रो सर्जरी डिपार्टमेन्ट, हाम्रो अर्थोपेडिक डिपार्टमेन्ट आर अल वेल इक्विप्ड डायग्नोसिस गर्नुको लागि। एन्ड द क्लिनिकल स्याम्पल माइक्रोबायोलोजीमा प्रोसेस गरेर डायग्नोज गर्नुको लागि हामीलाई वी आर एफिसिएन्ट फर द्याट। एन्ड अनदर थिङ इज द्याट सो KMC टिम अहिले हामीसँग हुनुहुन्छ। सो उहाँहरू आउनुभएको बेलामा फेरि हामीले अर्को राउन्ड अफ अवेरनेस प्रोग्राम गर्नुको लागि हामीले गभर्मेन्ट अफ सिक्किमबाट अप्रुभल लिएको छ, MS STNM म्याडमबाट अप्रुभल लिएको छ। सो हामीले अवेरनेस प्रोग्राम एकचोटि सिङताममा गर्छ, फेरि नाम्ची डिस्ट्रिक्ट हस्पिटलमा पनि गर्छ, एन्ड STNM हस्पिटलमा पनि गर्छ। सो विथ दिस आई वुड लाइक टु conclude my briefing here. And the house is open for answers. यसमा के हुन्छ भने चाहिँ तपाईको यही साइन एन्ड सिम्पटम हुन्छ भने पेसेन्टलाई यही बिमारी हुन्छ भनेर चाहिँ भन्न सकिँदैन। पेसेन्टलाई चाहिँ तपाईको न्युमोनिया पनि हुन सक्छ। न्युमोनिया भएको बेलामा तपाईलाई कफ, लामो समयसम्म कफ, ज्वरो आउन सक्छ हैन। तपाईलाई स्किनमा घाउ भएर आयो भने त्यहाँ अल्सर हुन सक्छ, त्यो एरियामा पेन हुन सक्छ हैन। अनि पेसेन्टलाई सेप्टिसेमिया भएर आउनुभयो भने पेसेन्टलाई फिभर हुन सक्छ। अर्को कुरा चाहिँ तपाईलाई चाहिँ एब्सेस, तपाईलाई चाहिँ अब इन्टर्नल अर्गानमा तपाईको लिभरमा, लङ्समा, स्प्लिनमा, किडनीमा, प्रोस्टेटमा, तपाईलाई प्यारोटिड ग्ल्यान्डमा, तपाईलाई थाइरोइड ग्ल्यान्डमा तपाईलाई एब्सेस हुन सक्छ। द ब्याक्टेरिया त्यहाँ गएर ग्रो गर्न सक्छ, त्यहाँको टिस्युलाई ड्यामेज गर्न सक्छ र तपाईलाई त्यहाँ एब्सेस गर्न सक्छ। सो बेसिकली के भन्न खोजेको भने चाहिँ यसले चाहिँ जुनै पनि सिस्टम अफ द बडी, जुनै पनि सिस्टम अफ द बडी, जुनै पनि अर्ग्यान अफ द बडी, जुनै पनि टिस्यु अफ द बडीलाई इन्भल्भ गर्न सक्छ, इन्फेक्ट गर्न सक्छ। त्यस कारणले चाहिँ कुनै पनि सिम्पटम इन्भल्भ भएर चाहिँ पेसेन्ट आउन सक्नुहुन्छ। त्यस कारणले त्यो कारणले चाहिँ मेलाइडोसिस क्लिनिकल ग्राउन्डमा डायग्नोसिस गर्न पुरा गाह्रो छ। द्याट इज द मेन रिजन।
In other words, the symptoms of the patients, they are not so much different from the other diseases. For example, suppose I have a cough. This cough could be a common cough. It could be tuberculosis. So now how do we differentiate? Patient doesn't know. So what happens is, in a common cough, when we give simple treatment, it will go away within 1 or 2 weeks. If it stays back for more than 2 weeks or 3 weeks, then we start suspecting it could be tuberculosis and we ask for tuberculosis testing. Similarly, this particular disease, can present itself as any other type of disease. It could be a cough, it could be a skin lesion, it could be an abscess somewhere there, it could be septicemia, everything there. So how do we then know? So if the disease the patient is having, if it is not tackled with the usual course of treatment, then you should suspect maybe it is something else. So it's basically by exclusion. So you have given the normal treatment, thinking that usually that's how the doctors do. We start with the broad spectrum antibiotic first, then we send for normal usual cultures that we know, and then we start treating with that culture, but still the patient is not improving. Now this is the time we will start thinking maybe it is something else, maybe something else is this, melioidosis. So that's what the awareness we are trying to create. If the patient is not improving with the usual course of treatment, then you please ask for this particular infection. So straight away, nobody asks for this treatment because it is not that commonly seen. So as you heard from her, we have tested all sorts of patients from different parts of Sikkim, even Nagaland and even Arunachal Pradesh. We have not seen this in the samples that we have created. That doesn't mean that we don't know how to diagnose. We know how to diagnose, but the patients may not be having this. But if you do more sampling, maybe some patients will be diagnosed.
So till now, so there is no vaccine has been developed. So the antibiotics are effective. So antibiotics are given in two phases. There is something called acute phase treatment, and there is something called eradication phase treatment. So that the doctor will ensure that after completion of the eradication phase treatment, the patient, the recurrence will not be there to the patient. So the infection will be treated in the two manner. Acute phase treatment will be targeted minimum for 2 weeks. Your acute phase, during the acute phase, antibiotic will be given by the intravascular route, and after the acute phase, in some of the patients, acute phase treatment may be extended for 8 weeks, and after acute phase treatment is over, then the eradication phase treatment will start. So their antibiotic will be given orally, minimum for 3 months it will be given. In some patients, it may be given for 6 months, and in some patients, lifelong eradication phase may need to be continued. So this we need to understand, because the treatment regime is totally different from other bacterial infections. So because of that reason, the high degree of clinical suspicion should be there. So because of that reason, we are here to create awareness among the general public. We are here to create the awareness among the healthcare people regarding the signs and symptoms. And जब से patient चाहिँ क्लिनिसियनकोमा जानुहुन्छ त्यतिखेर चाहिँ रिस्क फ्याक्टरको पनि हिस्ट्री लिनुपर्छ, लाइक पेसेन्टलाई डायबिटिज छ कि छैन, क्रोनिक रेनल फेलियर छ कि छैन, लिभर डिजिज छ कि छैन, क्रोनिक लङ डिजिज छ कि छैन, एन्ड इन्भाइरोमेन्टल हिस्ट्री लाइक एक्सपोजर टु सोइल छ कि छैन, गार्डनिङ हिस्ट्री छ कि छैन, फार्मर्स हुनुहुन्छ कि हुनुहुँदैन, सो पानीको ड्युरेसन, पानी परेको रेनी सिजनमा गएर बारीमा काम गर्नुभएको छ कि छैन. सो दिज अल आर द इन्भाइरोमेन्टल रिस्क फ्याक्टर्स. सो क्लिनिसियनले हिस्ट्री लिँदाखेरि, so all this history, environmental history, and then the patient को risk factor will be taken, so that this will help in the coming to the diagnosis. And इन्फेक्सन चाहिँ तपाईलाई कस्तो छ, यो ब्याक्टेरिया तपाईको सोइलमा छ, माटोमा छ हैन सर. सो सबै ठाउँको माटोमा ब्याक्टेरिया छ भन्ने छैन. कुनै ठाउँको माटोमा ब्याक्टेरिया छ, कुनै ठाउँको माटोमा ब्याक्टेरिया छैन. तपाईको ट्रपिकल एन्ड सब ट्रपिकल डिजिजेस, मेनी ट्रपिकल एन्ड सब ट्रपिकल डिजिजेस अफ मेनी कन्ट्री दे हैव रिपोर्टेड प्रेजेन्स अफ बर्कोलेरा सुडोमाली इन द सोइल, माटोमा. एन्ड बर्कोलेरा सुडोमाली यो ब्याक्टेरिया माटोमा छ भने चाहिँ हाम्रो ह्युमन बडीमा कसरी घुस्छ भने चाहिँ स्किनबाट, स्किनमा घाउ छ भने स्किनबाट घुस्न सक्छ. अनि तपाईको सास फेर्दाखेरि, लाइक त्यही भन्छ हामीले रेनी सिजनमा चाहिँ माटोमा भएको ब्याक्टेरिया चाहिँ एरोसोलाइज हुन्छ. सो त्यसले हामीले इनहेल गरेर रेस्पिरेटरी रुटबाट भित्र पस्न सक्छ. और हामीले untreated water खाँदाखेरि through oral route, through consumption of untreated water also, yeah, it can enter. Yeah, actually for this normal antibiotic, कुनै sophisticated antibiotic होइन, normal antibiotic जुन चाहिँ ग्राम नेगेटिभ बेसिलालाई काम गर्छ त्यही नै चलाउँछ. Only difference चाहिँ ड्युरेसन लामो छ, डोज फरक छ, त्यति मात्रै डिफरेन्स.
This antibiotic is available, it's a general antibiotic. It's a same antibiotic which is available everywhere. Only thing is, the thing is, you should know which antibiotics to be used. Everything is available. Everything is available. It's not.
So the antibiotic can be administered in any of the
Any hospital. This antibiotic is used by all doctors at all levels, even PHCs or primary care centers everywhere. The only thing is you should know which antibiotics to be used. We may be using the other antibiotic. There are different types of antibiotics. So it is available. All doctors can administer this at all levels. It is nothing special, which is not a different antibiotic which cannot be administered at lower levels or government or private. It's nothing like that. The only thing is diagnostic facilities available here.
Yeah, actually for this project, so when we get the sample for the routine investigation, for the routine investigation, as usual the patient will pay because in the routine investigation we use the automated system, whereas in the Burkholderia pseudomallei we diagnose the case by the conventional method, and when we need to repeat the sample from the suspected cases, in that case we do not charge to the patient.
We have made a brochure, which is like a patient information brochure, so which we have given to all of you also. I would be happy if you can, when you cover this press conference, if you can publish this also. It will be very useful to everybody. So every details are there in this particular brochure.
So actually, in the project, inclusion criteria has been laid down. Means which patient are we supposed to recruit in the study. So as per the inclusion criteria, like community acquired pneumonia, community acquired sepsis, abscess in the internal organ, bone infection, joint infection, skin infection, on-healed ulcers. So those are the inclusion criteria. Based on the inclusion criteria laid down in the project, the patient has been recruited. So till now we have recruited 145 cases in the project, and till now we have processed all the samples as per the protocol laid down, and we have not detected any sample. And another thing is that in the project, twice in a year there will be the external quality control. The lab will be assessed for the quality checking will be there. So when we send the sample for the reference center, all our report is for 100% confidence.
The method is almost similar to diagnose any other bacteria. Only thing is you need a different probe for this particular bacteria.
Yeah.
That's all. That's the method is same.